So today we're going to be focusing on behaviour that challenges. We hope to give you some information about why these behaviours might arise. We'll also introduce you to the recommended approaches for understanding and managing behaviour. And we'll also signpost you to resources for support and information. And as has been said at the end, we're very happy to take questions. So I can encourage you to put them into the chat. So this is my personal interest. This is my daughter Lara, and she's now of an age where it would be impolite to disclose how old she actually is. And she has Dravet Syndrome. And as every parent says, she's gorgeous. But seriously though, our fundamental aim as parents, as carers, as professionals, is to maximise the quality of life for the individual that we're involved with. And even when we experience and are faced with the challenges that difficult behaviour can bring, I hope you'll agree that these moments, these are the quality of life moments, as you will, these are what sustain us. And this is sometimes it's not an easy area to discuss. So I hope that you can be reminded of those moments as we go through the talk today. We could have the next slide. So, through this talk, we'll be drawing on research and recommendations for individuals who've got learning disability, autism, and other conditions, as well as our own experience. And I think because it's such a wide-ranging literature, I think it's helpful to have definitions so we're all on the same page in terms of what we're talking about. Now, this is from the Royal College of Psychiatrists, and I'm sure you can read it, but for those of you who are on phones, behaviours of such an intensity, frequency or duration as to threaten the quality of life and or the physical safety of the individual or others, and is likely to lead to responses that are restrictive, aversive, or result in exclusion. And I think you'll notice on the title that then they were referring to challenging behaviour, whereas the preferred term now is behaviour that challenges. And this is in recognition that the behaviour is not just the responsibility of the person who is expressing themselves in that way, that actually it's a result of an interaction between them and their environment. So we may slip up today and we may say challenging behaviour, so I apologise in advance. Sometimes behaviour that challenges is a bit of a mouthful. So the kind of behaviours that we're talking about are behaviours that are externalising, so aggressive behaviour, so that might be verbal abuse, threats or actual violence, destructive behaviour, breaking furniture and other objects, disruptive behaviour, so this might be spitting, running away, smearing faeces, and also some internalising behaviour, so self-injurious behaviour where individuals might bite themselves, might hit their own head, might hit themselves as well. And arguably, although these aren't really talked about it in this way, behavioural feeding difficulties could be considered behaviours that challenge, and also demand avoidance. And I think this also includes the silent refusals, the sit down and refuse to move. Those sit downs is something I've personally experienced with my daughter when she was younger and more ambulant. And I vividly remember the anxiety of crossing a road with her should she decide to sit down in the middle of the road because she didn't want to go that way. Now, some of you might not recognise these behaviours that you see under these kind of definitions. And certainly when we've presented to other parents, they talk about much less risky behaviour, but they would still nevertheless consider them to be challenging. Behaviours like repetitive questioning, for example. So hang on there with us, because it's important to consider all aspects of behaviour that you perceive to be difficult under the frameworks that we'll be talking about. And I think, whatever the behaviour, what we do know is that there's usually a gradual onset. It might be less frequent or less intense at the beginning, and families and schools and care home settings might tolerate it for a while. They might consider it, and they might see at that very moment in time and understand why that young person is expressing themselves in that way, for example. And we're also quite good, I think, at tolerating these kind of behaviours. It's just part of caring for our child. Often some intervention is started, sometimes because the behaviour is not perhaps fully understood, or it becomes a little bit difficult to intervene with. Sometimes the intervention is perhaps not as adequate as we'd like. And what we do see with some individuals is then that there's a gradual escalation of the behaviour in terms of risk and frequency, for example, but that requires more significant input. And I think it's important to recognise that the earlier and the milder, less risky behaviours are much easier to resolve. And that's not just because of the behaviour itself. I think it's also because of the impact that we see on the family and the resources available to actually resolve some difficult behaviours. So how common is it? And as I said, this is from the literature talking about people with learning disabilities. So we know it's experiencing behaviour that challenges is 3 times more common in children who have any kind of disability. It does vary with age. Some research is suggesting that it can peak in late teens and the early 20s, and then gradually reduce thereafter. Some severe behaviours are persistent over time, and this is particularly with self-injurious behaviour. But when it emerges in young children, then there is some evidence to say that it can also disappear over time. And I think if you read this, you might be thinking, if you're thinking about your young person, thinking, my goodness, I might be stuck with this forever. But intervention is possible, is helpful, and we can support families to bring about change in these kind of difficult behaviours. So in Dravet specifically, I wasn't able to find anything specifically relating to behaviour that challenges in Dravet syndrome. In our myself, Annemarie, and 2 of our other colleagues collated the information from a number of the families that we'd seen, and within that cohort, there's 33 families that were included in this. We identified 24% who had behaviour that challenges, but there was more who had features, and by features what we mean is that perhaps risk of or some emerging difficult behaviour, and also 12% with behavioural feeding difficulties. So we've got some evidence there. The fact that we're giving this talk, the fact that you're here listening to us, is the evidence that it matters. But there has been some research looking at what factors might link to quality of life, and also some descriptions of behaviour problems more general. So they're talking in here things like having ADHD, for example, rather than the kind of behaviour that challenges that I described before. But I think what is consistent across this literature is that in both these studies, that behaviour problems were the strongest predictor of the quality of life experienced by these individuals and their families. So it's important to consider this. So what are the risk factors? And what we mean by risk factors is that these are things that increase the chance of a difficult behaviour emerging. And this is a complex interplay between biological factors, psychological factors, and as I'll talk about in a second, environmental and social factors. And you'll see it's a complex interplay. Individuals who have language problems, who have difficulties communicating their needs, where there is an intellectual disability, so cognitively understanding, for example, their world and their life. Having social communication difficulties is a factor. Not understanding the way that one should interact with another, or why somebody might be interacting with them in a certain way. So these all produce difficulties understanding. Attention and self-regulation difficulties, impulsivity in particular, can play a part in behaviour that challenges. Where young people or individuals have a sensory impairment like hearing or visual impairments, that can have an impact on increase your risk of behaviour that challenges. And also physical health difficulties. The next slide. And I think if we think about the features and comorbidities that can happen with individuals who have Dravet syndrome, what we know is that these individuals can, as well as Dravet, have a language disorder. Intellectual disability is common. Autism is common, as is ADHD. And then, of course, the important part of the physical health needs, this is the impact of seizures, motor coordination, and sleep problems. So it's unsurprising that we might see behaviour that challenges in Dravet syndrome. And these needs that these individuals, or differences that they have, it interacts with environmental and social factors. So these, presenting a young person with changes that are unexpected may increase the risk of a difficult behaviour. When the environment is mismatched with their own needs, so if at a very simple level, if the language that is used around them, for example, is at the wrong level for them, then they're not going. That is a mismatch between their needs and the environment. The environment can be under or overstimulating. Annemarie will talk about occupation and how important that is as well. That being engaged with your environment at the right level for you at the right time is important. Sadly, we have heard of cases where environments can be restrictive or abusive, and also if carers are not able to provide good quality engagement with individuals, that can also be a risk factor. And that's not directed necessarily at parents. This can be in care home environment. This can be in a school environment where linking perhaps to the mismatch between the environment and the individual's needs. That actually this doesn't have to be a negative thing, that the environment suggests that in a school there are 10 children in a class for children with special needs, and moments in the day necessitate that a particular individual can't have the engagement that they need at that moment in time. So this is not all about negative experiences per se. If you're experiencing behaviour that challenges within your household, then I don't need to tell you what's on this slide. You will be living and experiencing this, but it has a significant impact on the individuals themselves. Through social exclusion, through physical harm of themselves, and they experience greater stigma. For you as carers, the increased risk of physical and mental health problems. I can't see you all now, but I'm sure if I put my hand up, if I ask you to put your hands up, I'm pretty sure that most of you will be experiencing lack of sleep and stress, and risk to carers for actually receiving physical injury is not uncommon. affects family finances. Your quality of life is reduced, both from accessing social leisure and feeling isolated. I think this is a common experience that parents report. And I think, this isn't, I haven't put COVID in here specifically, but COVID is another environmental challenge that is hitting us all, the individuals themselves and their carers, and also the siblings. Nobody, I think, escapes the impact of behaviour that challenges. And I think it's important, this, parents are the first to recognise, but there's been research looking at their experiences, and they all consistently report a lack of training and lack of understanding in how to manage their child's behaviour. But I think, as we talk about the kind of supports and links to other organisations, things are changing, but they're still not perfect. Okay. So, how do we help? And I've put at number 1 here is taking care of yourselves and seeking support. We're going to talk about that more towards the end, but it is the first thing that needs to be on the list. You are responsible for the care of your child, and so for you to be in the best place possible to do that is the ideal. The next thing is we need to understand the behaviour. We need to identify a personalised plan to manage that behaviour, and we need to make sure that the people around that individual are trained appropriately. So next slide. So PBS stands for positive, the PBS Academy in the corner, it stands for Positive Behavioural Support. And the recommended approach to managing behaviour that challenges is positive behavioural support. And this is a system that is focused on understanding the behaviour with a phased approach, analysis. It's person-centred. I think the key about this is combining perspectives from parents, carers and professionals to comprehensively assess and understand what is going on. Taking a life history approach, thinking about physical health and the emotional needs of all involved. This is what a positive behavioural support plan should produce. And I think it's important to say here that you as parents and carers are probably doing much of this in terms of you're thinking, you're trying to understand, you're already doing this. Every time your child behaves in a certain way, why did he do that? Was it this? Was it that? But this is a systematic way of doing so. Importantly, for some individuals, considering the medical and pharmacological aspects of both physical and psychological health, and I think for young people with Dravet syndrome, this is also a very important area, given the epilepsy needs of these young people. And I think this whole approach emphasises the individual in their context, in their environment, which includes family, school, college, so on and so forth. Next slide. The first thing to do is always to rule out pain. And especially if the behaviour is new, you've never seen this before, or if an existing behaviour has increased in frequency and or severity. But check anyway. Regular health and dental checkups, I'm teaching you how to suck eggs, are really important. And I'm sure for those of you who've got older individuals or parents of adults, you're aware of the over 14th NHS Learning Disability Annual Check that is now in place. You do need to register on your GP's register to make sure that you have access to this free annual health check. But ruling out pain is the first thing that you do. So the first part in understanding where this behaviour is coming from is to engage in what we call a functional assessment. Many of these young people can't tell us, why they're behaving in a certain way. And I'm sure many of you have asked your children, even if they can't respond, why are you doing that? But this is, can we make some deductions through observing the behaviour? And this process is about trying to find the patterns. Why is that behaviour happening? What might be causing it? What might be keeping it going, maintaining it? And we're gathering evidence, and we are testing hypotheses. We're trying to make, we're observing and we're obtaining information from yourselves and from other people who are involved with this young person. And we are testing our hypotheses. This process can't, definitively say this behaviour is caused by that and it's for this reason. We do our best work in trying to understand it. We do need to think about what's been tried before with families. We need to think about as I've said before, the relationship between the personal and environmental triggers, the behaviour, and what things that actually keep the reinforcers, things that keep the behaviour going. What's helpful in doing this is actually, before you intervene, is having a good description of what's actually happening. How often does this behaviour occur? How intense is it? How severe is it? Because that helps us test our ideas about what's occurring when we start intervening. Some of you may have seen these kind of ABC charts, and this is a functional analysis of behaviour. So this is where we might be now focusing on a very specific behaviour that we want to understand, and forms part of that overall functional analysis. And this is a method of systematically recording things that happen that lead up to the event, the antecedents. So this might be what you might think is a trigger, but also encouraging people to describe what's going on around that young person, the setting and the environment, whether there were any particular significant events, how that young person was feeling that day, whether the mood, their mood, and for families with Dravet, whether or not they've just had a seizure or you think a seizure is about to happen. So taking into account their physical well-being as well. Then you describe the behaviour that you see, and the frequency, the severity, and the duration. And then the last part is actually what happens after that behaviour has occurred. How do people respond? What happens to the child's behaviour, demeanour, and mood? And what this helps us to do is it helps us to differentiate what might cause a behaviour, so the antecedents, but also what may maintain the behaviour, and often inadvertently through what happens afterwards, the consequences of the behaviour. So this is an example. I'll read it just in case you can't see it. But so the antecedents. I came downstairs wearing my coat, picked up my keys, and put my shoes on. Sorry, I'm reading that badly. Brother took Billy out onto the trampoline. Then describing the behaviour. Billy runs back to me, grabbed at my clothes continuously until I intervened to a level that was close to ripping them. There was no shouting or anything like that. And what happened afterwards? Well, I gave Billy a kiss, and Billy wandered off in a calm mood. So that shows you what a completed form might look like. But there's a note of caution, as you will, because thinking back to the hypothesis testing, we don't really know with this one example why Billy wanted to grab the clothes. We might have we could probably have a guess, but I just want to emphasize here the importance of repeatedly observing behavior, because it's only with the repeated observations can we identify patterns, which gives us a better idea as to actually what this behavior means to Billy, and why he might be doing it, what is its function, what is the need he's trying to express. Thank you. And so using that information, where could we intervene? Sometimes it's 1, 2, or 3. So we could intervene at the antecedent stage. We could try and remove all the triggers. And for some situations, this is the right thing to do, and it's entirely appropriate. But sometimes the triggers are the things that actually are core to an individual's life. So you can't, if a trigger, for example, is going on getting on the school bus, removing that trigger will be extremely challenging, because the child needs to get on the school bus to go to school. Can we intervene at the behaviour stage, telling them to stop? We will all have done this. We will all have asked our child to stop, either saying it or physically moving their hands down. But I think, if we ask ourselves, does it work? I think we can all agree that it doesn't. But we can teach an alternative behaviour if we know what the function of that behaviour is. If that child is continually hitting out at another child, we might understand and recognise that what they're actually saying is go away. So we can teach them another way to say go away that's more acceptable. We can also think about intervening the consequences phase. So the behaviour no longer gives them what they want. This isn't always possible. It's an important step, but it requires a high level of consistency. And I think if you're seeing a behaviour across environments, you might be able to be incredibly consistent within your own home, and changing what happens after the child's done engaged in the behaviour. But actually, in a school environment, or if you're out socially in the supermarket, you're not in control of other people's behaviours. So there's all possibilities to intervene at all these levels, but this comes back to the individual and the family and the actual specifics of this particular behaviour, and where we decide the best place to intervene is. So we have our results of our assessment, and this should result in an individualised intervention, a behaviour support plan. And this should include functional communication training, if appropriate, proactive strategies and reactive strategies. So we'll talk about each of these as we go on. There's a big note. When you're intervening in a difficult behaviour, well, any behaviour actually, this applies to any kind of behaviour. What the literature tells us is that if you see the blue line, that is where the intervention starts. And what you'll see on this graph shows is that there's a honeymoon period where the intervention starts. You see a reduction in the behaviour, or an increase in the behaviour that you want. But then what happens, and happens quite consistently, is there is this peak where the behaviour re-emerges and feels and is worse than it was before. They call this an extinction burst. Now, our experience with families, and my own experience as a parent, is that getting through that extinction burst, that peak and worsening of the behaviour after the intervention, is the toughest time. And it's often here where families, particularly if they're unsupported and they're not aware of this, for example, give up and return to tolerating the difficult behaviour. And I think this is where the support is really important in helping families get through this extinction burst, because as you can see, it then rapidly declines again. You might get a couple of blips with the behaviour, but actually being consistent in your intervention will get you through that extinction burst. Thought it'd be helpful just to share before we get into more of the details of intervention, is that there are, when we think about difficult behaviours, there are 5 common functions. So this is when we're looking at information that families are giving us. These are in our mind. Is that often it can be to indicate need for help, to get attention. It might be to escape from stressful situations or activities, or it might be actually to get something that they need. In the example I gave, for example, we could say that actually because his mum always kissed him when he did that, when he pulled on her clothes, that was his way of asking for a kiss, for example. We don't know that, but that's an example. It might be as a protest, and this might be about unwanted events or activities. And for some individuals, it might be to obtain stimulation. So most of these are communication based, but also potentially related to anxiety. I've included the function of restrictive and repetitive behaviours. Autism is common in Dravet Syndrome, and these repetitive behaviours are all part of autism. The reason for including them is that they're often particularly relevant where self-injurious behaviour is the difficult behaviour that we're trying to address, and so should be a part of our understanding, because the function of these behaviours can include increasing the predictability of a routine and thus decreasing anxiety. It might be about maintaining their own environment in a way that they understand. It might be because they have no alternative strategies, but also there can be a way to occupy oneself because they have no alternative ideas, for example. So on to interventions more specifically. So functional communication training. This is about replacing a problem behaviour and strengthening a socially acceptable alternative. So I've given an example here of a child who is unable to use words to communicate, but who would bang her head off the table every time she wanted more juice. And her mother would respond by filling her cup. So what you might see here is that mum, in understanding her child's needs, has inadvertently reinforced that this is a way that this child can ask for juice. We can see here that actually there's a better way to ask for juice, and this is where can we teach this child to ask for the juice in a more socially acceptable way. What's key here is that whatever method of communication we use, it needs to be less effortful than the actual problem behaviour. The quicker it can be learned, the better. We don't want to, if it's easy to hit your own head to get your drink, for example, than to say, for example, to be taught, please mummy, can I have a drink? But if we perhaps got the child to hand over a picture, which is as quick as hitting, that would be less effortful and still socially acceptable. We need a slide on the impact of epilepsy, in the case of Dravet syndrome. We need to think about the impact of epilepsy itself on sleep. The child I talked about before, they experience sleep difficulties for a different reason. But if your child is having seizures in the night, a typical sleep management program, would not be helpful in the same way. Thinking about the seizure activity itself, both before, during, and after, the risks of irritability, anxiety, headache, and fatigue, and all of those things you've seen are factors, risk factors in behaviour that challenges. But also the potential, some of the epilepsy medication may have side effects that affect mood and behaviour. Now, I am not a a medical person, so you know, I'm not going to take on listing what side effects or what medications are relevant, but you know, this is something that you should be discussing with your medical practitioner. And I'm now going to hand over to Annemarie.
Thank you, Penny. So I just want to take this opportunity, because I take any opportunity I can to speak about the subject, because and it's probably because I'm an OT and I read lots of reports from OTs, and this sort of over focus on a sensory framework for looking at behaviors that challenge. So I just want to take a moment, and I'll try not to go completely off on this, because I get quite passionate about it, but it does need to just be mentioned. I don't know how many of you, because I can't see you, have had this sort of explanation, but we just need to reframe how we look at some of these behaviors, because they often get described as being sensory seeking, and it makes it sound quite simplistic. That, for example, self-injurious behavior, hitting, biting, throwing things, you know, like smashing things against the wall, screaming, hyperactivity, that these are rooted in the child's sensory system and this need to do these. But there's a couple of dangers of looking at it in such a narrow framework. One is the behavior is what we see. And yes, there's a sensory element to all of our behavior, but we haven't actually, by just looking at that, we're not actually doing what Penny talked about. We're not looking at what actually caused the behavior in the first place, or what the child is reacting to, or what they're escaping from, or what they're communicating, which is looking at what it is they're actually doing. So we're probably missing a big part of that analysis and that understanding of behavior. And also our response, if we could just look at it from a sensory framework, your response might actually be maintaining it. So I've definitely seen situations where when the child started, for example, smashing something or the iPad against the wall, or throwing something, turns out, oh, they're sensory seeking. We must give them, when the sensory diet thing comes in, we must give them some of that input, and would go and perhaps give some, then do some deep pressure, which felt really good to the child, as it would to any of us. And now we're actually, the behavior became a way of communicating and actually requesting some sensory input. So we just have to be really careful not to look at it in such a narrow frame. Next slide. So either we get the sensory seeking kind of described behaviors, or you get the sensory avoidant behaviors. So children come home from school, or just feeling distressed, and they might go and want to hide in some dark corner or squeeze themselves into a small place. Difficult to take shopping, difficult to take to birthday parties, don't like busy places. The intolerance of school uniform, doesn't like the feel of it. I hear this quite a lot. But actually, if you don't want to go where the school uniform sort of is a cue that you're going to go, then actually it's going to feel a lot more uncomfortable than it would if you were very happy to go. You would probably tolerate that slight discomfort or even heightened discomfort better. Narrow diet. Yes, there's a sensory element to eating, but there's also, you need motivation, you need an interest in new things, and often there's a drive for sameness and just keeping things really predictable. So this intolerance of uncertainty definitely comes into all of this as well. If you just keep things the same and the same experience, I'll be okay. So this is just to kind of make the message that we all have our sensory thresholds. This is way beyond mine. And actually, I think in this time, this is a really bad slide, because obviously this is completely against the law and they all have COVID. But I think the point is, this is my sensory threshold. There's no way I would walk into this kind of pre-COVID at any time. Like the smell, the noise, the sounds, the social aspect, all of it. So maybe for some children, actually, the supermarket, maybe actually the birthday party is their threshold. And that's okay. We all have our sensory thresholds. I think it's just an important thing to consider with food, with clothing, with everything. But if what the child doesn't tolerate, or a young person doesn't tolerate, is actually getting in the way of what they want to do. So they want to be able to participate in a mealtime with the rest of the family, or the rest of the family needs to be able to go to visit other family when that's allowed, and be there. Then we need to work on building tolerance and problem solving, how we manage that. But if it's just an intolerance of this, then you can happily go on without doing that. Does that make sense? So next slide. So just to remember, everything we experience has a sensory component, but nothing is only sensory. And that's definitely true for behavior. Behavior is what is the sensory bit is what we see. There's always a lot more to it. So I will I'll move on from that sensory talk. I'll probably end up going back to it. So go on, next slide. So as Penny mentioned, we're talking about strategies. These are taken from the NICE guidance on managing challenging behavior. So these are our proactive strategies. So we often, again, when we've done the problem solving that Penny talked about, we've looked at what happens before the behavior, and we think about how we can actually help problem solve this. We could look to change the environment. And yes, you are going to look at the sensory elements of the environment. So there, back to my slide. If there's something environment that the young person just can't cope with, what can we physically adjust? But also, what can we socially adjust in the environment, and what can we adapt to help them, perhaps with their communication, make it a little bit easier? So we need to look at all aspects of the environment. The next point is what, as OT, I feel really quite passionate about, and I get quite involved with, is this promoting activity and occupation. Because if we can stretch out in a day how much time the child is spending, or the young person is spending, doing purposeful occupation, engaged in other activities, there becomes less time for perhaps some of those repetitive, maladaptive behaviors that we see. So we need to think about their everyday. And sometimes the children we work with, we definitely hear that there's sometimes less of these challenging behaviors at school. And often it's just that structure, that predictability, that lack of sort of downtime. So this would obviously come out when you've done the analysis of when do you see the behavior. And I have a case study, I'll bring all this together. And then, so that's definitely one thing. We need to think about how we can help, perhaps make a list. So one thing I often recommend is making a list of all the things the child enjoys and participates in, even if it's just momentarily, participates in during the day. And that's where you would include the sensory activities. So if someone likes a bath, they like throwing things, they like jumping, or they like just licking, touching, let's put those on the list and then see how we can use those to make them actually more meaningful activities to engage the child, rather than think of it as a pathology, that's something we need to fix and treat out of them. I'm doing it again, I'm going on to the sensory, but it's often thought of as a sensory processing disorder, which is not a recognized diagnosis, and it's not a separate pathology. We need to work with these sensory differences to help increase the opportunity for different occupations. But also, as Penny's also talked about, improving communication and social interaction, because sometimes a behavior might be a social ritual. It might be a way of engaging someone. So for example, a young boy, where I think this is actually in my case study, but never mind, where grandma enters the room and he would always pull off her glasses, and that always got a predictable response. And that was his way of socially engaging her. So we had to teach her and him a different way to start off the interaction and immediately go into a different type of activity in order to extinguish that. And as Penn mentioned, the sort of calming strategies, I do want to touch on that again from a sensory framework, because the deep pressure, going into a dark space, these are things we would all like to do after a stressful day. I would love to go home and just go onto my duvet with a cup of tea and some calming music. Never happens in our lives, but wouldn't that be lovely? So when do we offer these? When do we help the child to self-regulate and look at what actually calms your individual young person? And when do we do it? So we're not doing it when they're at the peak of a behavior we're trying to manage, but we might just actually incorporate that in the day to just kind of help them to learn to self-soothe. That makes sense. So next slide. So as I said, building on purposeful activity. Sorry, can you click one more time? So really looking in detail of where the child participates in daily routine, like I said, even briefly. So maybe actually you're managing in the morning to have the child get dressed, or you're dressing, whatever level of assistance you're providing with. That's complete dependency of the child's doing most of it, wherever you are in between. Maybe there's a few minutes there that actually they're following that routine and that goes okay. Maybe it's a moment of likes to take things out, taking clothes out of a washing machine, might be dumping it on the floor, but there might be a moment there, actually this is an activity that they go to, they like to do. Could be watering the garden, which might be literally taking a bucket and pouring water in the mud, and maybe slightly undesirable, but there's something there that actually they participate in, they purposefully do or seek to do. And again, unpacking groceries, just taking things out of the bags, which can feel like it's a behavior you need to change. But how do we take these little moments and build on them and try to teach skill and make them more purposeful and expand on occupation? Sorry, next slide or next click. What we might do is add on a step or increase the frequency that you're seeing these behaviors. So, for example, with the dressing, if that's a part of the morning, that's okay. You're not there, you're going to spend more time doing it, but where could we build on just the young person spending it more time doing it or doing a little more for themselves? So you have that moment for them, give them that deep pressure hug that feels good, or have that sensory toy because, wow, they did really well participating in that. Could that be lining up the clothes before putting it on? If you're at this point handing piece by piece, could we do that? Or just could it be wherever in their ability able to participate? Could they do one step more? So we're doing a little bit more of that functional activity, just progressing it a little bit, step by step. Taking the basket of clothes to the washing machine, or learning just to put it in, or maybe just twice a day. Oh my goodness, look at that. There's a bunch of towels in the washing machine. They need to come out and go in a basket. So we build in these occupations throughout the day, building on what they're doing in the garden if they like to be on there. And again, how we make things meaningful in things that you're doing anyway, so that you're doing it alongside the young person. If you feel like you always have to supervise, you have to be there, just do something together that's a little bit more an occupation, an activity, functional. And it may start really, really small. I think that's the key. We might be talking about 2 minutes, about one can out of the grocery bag, but we've got to start somewhere, identify that. Where do we start, and then where do we build on that?
I think I've mentioned some of this before, that medication, sometimes the behaviour is so overwhelming for the families that actually engaging in a behavioural intervention is too challenging or too risky. Sometimes families have engaged in a behavioural intervention, but the success has not been as we would have hoped. And these are the situations where medication may be helpful. This is the guidance from NICE about the use of antipsychotic medications. But there are also other, it may be, for example, that a child has ADHD, and in which case, if impulsivity is underlying some of these behaviours and persistence of these behaviours, then actually medication for ADHD may be beneficial for that reason as well. It may be to use to lower the level of overall agitation, and this is where it might be helpful. Or if anxiety is considered to be an underlying problem, if a child's degree of anxiety is so significant, bringing it down might make them more amenable to responding to a behavioural intervention. Next slide. Now, reactive strategies, these refer to strategies that are required in order to continue to keep an individual safe, to minimise or eradicate risk. Now, when you've got a little child, this is much easier to do because you can often pick them up and remove them from the situation, or they're probably small enough to, as with Annemarie's case, to hold. But as these young children get older, these strategies are obviously bring about their own risks. And so if they are required, then they should be thought about thoroughly. They can include physical holds, it can mechanical or manual restraint, and this can be things like splints if to stop a child from hitting themselves. Sometimes it's about seclusion, removing them to a safe space, and also sometimes using emergency medication. Next slide. It's important to recognise these are not designed to bring about long-term behaviour change. These are about keeping about safety, and they should be used as a last resort, and only ever used when you are actually trying to engage in proactive interventions to actually address the behaviour that challenges. They need to be ethically delivered. You need to put that individual at the centre of decisions about what these kind of strategies are required. You need to use the least restrictive first, and you as family and carers need to be involved, and they need to be reviewed regularly. One of the families that I worked with, splints were needed because he would always hit his head, and he wanted to restrain himself, and he was doing that by trying to get people's hands. And so we had long discussions about how we could, in our use of these, our recommendation of the use of these, we also included recommendations about how we stop him from using them, how we wean him off using them, and which we were able to do. Next slide, Annemarie.
So very quickly, we all know sleep is really, really important. And again, we know with the Dravet and obviously the seizures are happening in sleep, that's going to impact everything else we do during the day. So just recognizing that a lot of strategies only go so far when everyone's sleep deprived, and just how important that is. And looking at that as a challenging behavior, and how can we get the best sleep, and the importance of just the sleep hygiene program. I know you've all heard this before, which is add the medication. The medication alone, of course, won't solve all your sleep problems. And so it should really be, the sleep medication should be in consultation with specialist pediatrician, psychiatrists who have the expertise in its use, but in conjunction with some of these behavioral interventions. What's maintaining, especially, the children wake at night and then come into your bed, or don't sleep in their own bed, and all these kinds of behaviors that can just maintain really dysfunctional sleep. There's no slide here on feeding, but I can fish for an invitation to come back. I'd be happy to talk about it for an entire hour and a half, because I was working in the complex feeding clinic. I think the feeding behavior and mealtime stresses is another really important one, because that happens every day, at least 3 times. And if meal times are, what are we going to eat? How are we going to get food? And that narrowing diet. So that would be another target area to lower family stress. So happy to talk about that anytime you want. Sorry, but I won't now. Don't worry. Next slide. I think this is really important, because we can talk about all this, and I think the strong message Penny and I want to send, which you absolutely know, is that there's no magic wand. There's no just do this and you won't have to deal with this. This is really difficult. This takes a team approach, with you being the most important member of the team. This takes a lot of work. And why is it always more difficult at home? Why do we sometimes, schools go, we don't have nearly the problem at school. Well, of course you don't. First of all, they have a lot more personnel. So you might have a totally different ratio. This idea of being with the child and guiding and supporting and teaching, they can do that. And they're only doing it from 9 till 3:30. As one teacher said to me last week, I go home at 5 o'clock and then I get a really good night's sleep and recharge. I'm thinking, yes, parents have no such luck. So it's a different environment, and that really needs to be considered. The other thing is, I think often hear from parents, and I'm sure you can all speak to this, that this idea of, if I do something, this could get worse, and I just don't have the resilience to deal with that right now. We've found a way to live with this particular behavior. So we're just going to carry on, especially if the child is small, because actually can pick little Billy up and just, actually, we're going now, come along. But of course, knowing full well that in 2 years now, may not be able to just pick up and move along. So completely understandable why it's taking that risk of actually making a change, and knowing things could get really difficult. It takes a lot of resilience. I've tried things, and parents, well, I tried that once, it didn't work. Well, no, and lots of things won't work immediately, and then we need to reanalyze and relook at it again. So when I talk about that case, the case study, I think the intervention we used was actually parent coaching. We were virtually doing lots of hand holding, and it is intensive. And I know you're going to be shaking heads going, no one's going to do that for us. But I think it's the next slide, actually. So I've gone to the next slide. Sort of who to ask for help, not to limit it to thinking, we need CAMS or we need a psychologist. I mean, I'm an OT and I do a lot of this work, and any OT I can get hold of, I will ask them to forgo handwriting in favor of using their time with the family to work on feeding, work on sleep, work on functional, work on these challenging behaviors, because it's not owned by any one profession. So ask everybody for help, and look for that kind of parent coaching, that kind of support where you're problem solving, you're doing something, you got someone to feed back to who's a little bit outside, who can actually go, yeah, this is probably why you got this reaction. Let's try this next time. Let me know what. I know that's really, really difficult, and we're lucky that we can often offer a little bit more of that, because it isn't something you just do, is it? And then, or in a block of therapy, or a whole, a handout. Do this, everything will be grand. It is really complicated. It is really challenging, and it's ever evolving. We solve some of this, and then something else happens. So ask anyone who's involved, because you just need someone with an interest, and it could be any professional. I say that as an OT. Next slide. I think we're almost at the end. Yeah, some other, we know it's the family that needs support to keep the whole family functional, safe. That we always see, of course, the young person in context of their family. They're not an isolated entity. They're all together. So identifying your local support groups, reaching out, some of these things that were listed on here that you have access to, so I don't need to read it out, but they do have helplines, using these resources, knowing this is, you're actually advocating for yourself and your child. This is not something, I should have been able to manage this. No child comes with a handbook, but especially this requires a whole different tool set that isn't readily kind of available to tap into. I think there's just one more slide on sort of some more links on support there. I know we're running over, and we wanted just time for questions as well, because I think it's really hard to give a broad, like I said, sort of broad overview of strategies, because it, as you can hear, it's very individualized. So it's very much looking at individual situations. But I think it's more giving you hopefully some guidance on asking those kind of questions, looking at it in that broader way, thinking about everyday function. Where's the behavior? Where do we need to intervene? Increase self-occupation. Is it about transitioning? Is it a communication? Really trying to better understand the behavior.